Welcome back to the deep dive. Today we're doing something a little different. We are pushing aside the textbooks and those dry, sterile definitions you might find in a classroom.
Right.
We're talking about something really visceral today. A moment in time where life and death literally hang in the balance and where the outcome is often decided by, decisions made in a single solitary hour.
It's a topic that sounds like it belongs strictly inside the walls of an operating theater or maybe an ICU.
Yeah.
But the logic behind it, what the source material calls surgical thinking, is actually this incredible masterclass in critical thinking under extreme pressure.
Yeah, exactly. Today, we are doing a deep dive into shock. And to kick this off, I want to put you, the listener, right in the middle of a high-stakes scenario.
This is the perfect way to start.
Yeah, this comes straight from our source material today, which is this really fascinating, comprehensive breakdown of surgical physiology. So I want you to visualize this. You're standing in an emergency room.
The lights are humming.
Right, those harsh fluorescent lights. The automatic doors just burst open. Paramedics wheel in a stretcher. And on it is a 25-year-old man. He's just been pulled from a really serious road traffic accident.
This right here, this is the beginning of the golden hour.
Mm-hmm.
The clock is ticking the absolute second he hits the door.
Exactly. Now, I want you to look at him. Really look at him. He's pale. I mean, sheet white, like the blood has just been totally drained from his skin. You look at his neck and you can almost see his pulse just hammering away. He's restless, kind of thrashing a bit on the gurney, looking confused, maybe scared, pulling at his clothes. And you look up at the monitor and you see his blood pressure is starting to dip.
If you are the doctor in that room, your brain needs to scream one word immediately, and that word is shock.
Right. But here's the thing, and this was my first big aha moment from the research stack today. When I hear the word shock in normal, everyday conversation, I usually think, oh, he's emotionally traumatized.
Right, the psychological definition.
Yeah, or purely from a medical side, I just think, oh, his blood pressure is low. But our expert source explicitly says that if you wait for the blood pressure to drop, you might have already lost the battle.
And that right there, that is the critical misconception that kills people. Shock is not just a number on a monitor. It isn't just hypotension.
So what is it then?
If we want to define it accurately, and this is the definition that actually saves lives, shock, is inadequate tissue perfusion. It is fundamentally a failure of the delivery system.
I want to stop you on that exact phrase, inadequate tissue perfusion. I mean, it sounds like textbook jargon. It sounds sterile.
It does.
But reading through the deep dive materials, you realize this is actually a description of a catastrophe, right?
Yeah, it's a physiological apocalypse. Let's really break it down. You and I are sitting here right now breathing.
Hopefully.
Right. We breathe in oxygen, it goes down into the lungs, the hemoglobin in the blood grabs it, and the heart pumps it out. That whole system, that's the delivery truck.
The logistics network.
Exactly.
Yeah.
But perfusion is the moment that delivery truck actually pulls up to the house, the individual cell in your body, and drops off the package. Shock is when that drop-off fails.
So the trucks might be on the road, the packages are loaded, but they aren't reaching the front door.
Precisely.
Yep.
Or maybe there aren't enough trucks, or the road is blocked. But here is why it matters, and this is the part people miss. Your cells are tiny engines.
Right.
They run on fuel, which is glucose and oxygen. We call this aerobic metabolism. It's clean. It's efficient energy. It produces ATP, which is the energy currency of life.
Like a hybrid car running on electric, just clean burning.
Perfect analogy.
Yeah.
But when you cut the oxygen supply, when that perfusion fails, the cell doesn't just turn off immediately, it panics. It switches over to emergency backup power. This is anaerobic metabolism.
Okay, I remember this from high school gym class. This creates lactic acid, right? Like when you sprint way too hard and your legs burn.
Exactly that. But in the gym, it just makes your muscles sore for a day or two. In shock, because it's happening to your liver, your kidneys, your brain, that acid starts to build up in the blood.
Oh, wow.
You are essentially turning the entire body into a toxic environment. The cell makes far less energy on this backup power. It generates massive amounts of acidic waste. And eventually, the cell wall simply breaks down.
And the cell dies.
It explodes, essentially. And it dumps all that toxic machinery straight into the bloodstream, which then poisons the neighboring cells. It's this horrific domino effect.
Right.
So when we say inadequate perfusion, we aren't talking about low blood pressure.
Right.
We are talking about a systemic energy failure that causes the body to literally rot from the inside out within hours.
That is a much heavier definition than I was expecting. It really changes how I view the whole golden hour concept. You aren't just fixing a plumbing leak, you're trying to stop a cellular meltdown.
And this is exactly why the literature calls it the silent killer, because the human body is incredibly smart. It fights back against this meltdown. It compensates.
What do you mean by compensates?
It can keep the blood pressure looking totally normal on the monitor, even while the cells deep inside are beginning to starve and switch to that toxic backup power.
So the monitor is lying to you.
In a way, yes. So if you are looking at a monitor just waiting for a crash, you are looking at the past. You need to look at the patient to see the future.
That sets the stakes perfectly. We are not just learning medical trivia today. We're learning how to spot a system failure before it becomes a total shutdown. And the source material uses this really fantastic analogy to break down why shock happens. It's the plumbing analogy.
It is absolutely the best way to visualize it. If you want to understand why perfusion fails, you have to look at the circulatory system as a simple hydraulic loop. You have three main components. You have a pump, you have pipes, and you have fluid.
The three pillars of perfusion.
Exactly. The pump is the heart. The pipes are the blood vessels. And the fluid is the blood itself. If any one of those three components fails, the system loses pressure, delivery stops, the cells start suffocating, and boom, you have shock.
And this simple framework actually creates the medical classification system for shock, right?
It really does.
Like, it's not just random Latin names. It's based entirely on which part of the plumbing is broken.
Correct. And this is where surgical thinking replaces blind memorization. You don't just memorize a list of shock types. You derive them from the plumbing model.
So let's walk through them. Let's start with the fluid.
Right. So this gives us type 1, hypovolemic shock. Hypo meaning low, volemic meaning volume. The tank is literally empty.
And this is the one our source identifies as by far the most common in a surgical or trauma setting.
Oh, by far. If a surgical patient is in shock, you assume it is hypovolemic until proven otherwise. And usually that means hemorrhage. They are actively bleeding.
But it's not always blood, right? The notes mentioned you can lose volume without bleeding a drop.
No, absolutely.
Yeah.
It could be massive plasma loss from severe burns where the fluid literally weeps out of the skin. It could be drastic water loss from catastrophic dehydration.
Like severe vomiting.
Or diarrhea, like in cholera, exactly. But in the trauma bay, with that 25-year-old car accident victim we imagined, it is blood. The rule of thumb is very clear. In trauma, it's bleeding until you categorically prove it isn't.
Okay, so that's fluid failure. The tank is leaking. Now let's look at the pump.
This is type 2, cardiogenic shock. The tank is full of fluid, the pipes are perfectly intact, but the heart itself is broken.
Like a massive heart attack.
Exactly. A massive myocardial infarction. A large piece of the heart muscle dies and just can't squeeze anymore. Or maybe a valve is suddenly blown out, the engine has seized.
Right.
Now here is where it gets really interesting for the clinical detective work. How do you tell the difference between the pump breaking and the tank being empty? Because in both cases, the blood pressure is low and the patient looks terrible.
Yeah, that's the trick. In both cases, the blood just isn't moving. But the source gave a really specific clue here, the JVP.
The jugular venous pressure. This is the big aha moment. Think about the plumbing again. In hypovolemic shock, the empty tank, the neck veins are flat. They've completely collapsed because there's just no fluid left in the system.
Like a totally deflated garden hose.
Precisely. But in cardiogenic shock, the heart can't pump the blood forward, so it has nowhere to go but backward. It backs up from the heart into the major veins and right up into the neck.
Oh, so you physically see distended veins bulging in the neck.
Right. The patient is cold and clammy, just
Yeah.
like the bleeding patient. But those bulging neck veins tell you, hey, the tank is full, but the pump has failed. It's a traffic jam because the car at the very front has broken down.
That is such a crucial distinction, because if you treat the pump failure by assuming it's an empty tank and dumping more fluid...
You kill them. You literally flood the lungs and drown the patient from the inside. This is why getting the exact diagnosis matters instantly.
Okay, moving to the third pillar, the pipes.
This is type 3, distributive shock. This is a fundamental failure of the tubing.
Meaning the pipes burst.
No, meaning the pipes get too big, they dilate. Massive vasodilation. Imagine you have a garden hose with a certain amount of water flowing through it. If that hose suddenly becomes 3 times wider, what happens to the water pressure?
It just drops to zero, just trickles out.
Exactly. The fluid is still there. You haven't lost a single drop of blood. The pump is still working hard. But the container the blood has to fill is suddenly way too big to maintain any pressure.
So it just sits there.
Right. The blood pools out in the extremities and doesn't get pushed back to the heart.
And this category includes some of the most famous types of shock we hear about out in the world, right? Septic shock, anaphylactic shock.
And neurogenic shock.
Yeah.
And distributive shock actually gives us one of the most counterintuitive signs in all of medicine. We call it warm shock.
This completely blew my mind when I read it, because usually when I think shock, I think of that cold, clammy, pale skin, like the guy from the car crash in our intro. But you're saying in this specific type, the patient can actually feel warm to the touch.
In the early stages of septic shock, yes, absolutely, because the core mechanism is vasodilation. The blood vessels right near the skin open wide up, so the patient feels warm and flushed.
Wow.
Their pulse is bounding because the heart is desperately trying to fill this massive new empty space.
So if you're a junior doctor looking for that classic cold, clammy skin, you might totally miss a patient who is actively dying of sepsis.
Exactly. A warm, confused patient with a racing heart is in septic shock until proven otherwise. It is a really dangerous trap for the inexperienced. They touch the patient and think, oh, he's warm, he has good circulation. No, he has failed circulation.
Man. While we're on distributive shock, we need to touch on neurogenic shock too, because the source highlighted a very specific paradox there that I want you to explain. This is usually tied to a spinal cord injury, right?
Yes.
Yeah.
Say our car crash victim broke his neck. The physical injury severs the connection to the sympathetic nervous system. That's the system that usually revs you up.
The whole fight or flight response.
Right. Usually in any form of shock, your body screams fight and your heart rate spikes to compensate for the dropping pressure. But in neurogenic shock, that vital communication wire is literally cut.
So the signal never reaches the heart.
Exactly. You lose the tone in the blood vessels, so they dilate, causing drastically low pressure. But because that sympathetic nerve is severed, the heart never gets the emergency signal to speed up.
So you have rock bottom blood pressure and a slow heart rate.
Exactly. Hypotension paired with bradycardia.
Yeah.
That combination is weird. Physiologically, it shouldn't happen. If your pressure drops, your heart should always race.
So if it's slow and the pressure is low and they just had trauma.
That is neurogenic shock.
That is fascinating. It's like the body's entire central alarm system has just been completely bypassed.
Precisely. The brain doesn't even know there's a fire.
Okay, so we have the pump, pipes, and fluid. But the source mentioned a fourth type that doesn't quite fit the pure plumbing analogy perfectly, or I guess maybe it's that it physically blocks the plumbing. Type 4, obstructive shock.
Yeah, this is a purely mechanical problem. It's not that the heart muscle is weak, like in cardiogenic shock, but that the heart is physically being squashed or blocked from filling up with blood.
And there is a great mnemonic here that I love, TCP, like a computer network protocol.
Yes, TCP. These are the three big immediate killers in obstructive shock.
Yeah.
T is for tension pneumothorax, C is for cardiac tamponade, and P is for pulmonary embolism.
Let's break those down really quickly for the listeners. Tension pneumothorax.
Air leaks into the chest cavity, maybe from a fractured rib puncturing a lung, but the hole works like a one-way valve. Air gets sucked in when they breathe, but it can't get out.
So the pressure just builds.
It builds up pressure until it literally squashes the heart and the major veins against the other side of the chest. Blood physically cannot return to the heart. It's a literal kink in the hose.
In cardiac tamponade.
Very similar concept. But instead of air filling the chest cavity, it's fluid or blood rapidly filling the tough fibrous sac around the heart itself, the pericardium.
The heart is basically being strangled.
Exactly. It wants to beat, it wants to fill with blood, but it's being aggressively squeezed from the outside.
And the P, pulmonary embolism.
A massive blood clot blocks the main pulmonary artery going from the heart to the lungs. The pump pushes with all its might, but it's pushing against a solid brick wall.
The TCP restart, the source says these conditions need urgent fixing, like right now.
Immediately. You cannot fix these with IV drugs. You have to physically relieve the obstruction. You have to decompress the chest with a needle, drain the blood from around the heart, or chemically dissolve the clot. It's a mechanical plumbing blockage that needs a plumber, not a pharmacist.
Okay, so that is our landscape, the physiology framework. But I really want to zoom back in on the most common type for our surgical thinking deep dive today. Hemorrhagic shock, the actively bleeding patient.
This is where we get into the ATLS classification, Advanced Trauma Life Support. This is the absolute gold standard worldwide for categorizing exactly how bad the bleeding is.
And this is where that silent killer aspect we talked about really comes into harsh focus. Because the body is surprisingly good at hiding blood loss until it just suddenly isn't.
It is deceptively good. The classification is essentially a sliding scale of 4 classes based on how much blood is lost and, crucially, how the vital signs change in response.
Let's start with class 1. This is what the source calls the blood donor.
Right. Class 1 is a loss of up to 15% of your total blood volume. In an average adult male, that's roughly up to 750 milliliters.
Which is basically what happens when you go to the Red Cross and donate blood, maybe just a tiny bit more.
Exactly. When you donate blood, you walk away, you drink a juice box, have a cookie. You're fine. Your pulse is totally normal, staying under 100 beats per minute. Your blood pressure is normal. Your body compensates so beautifully that you barely even notice the missing volume.
So clinically, if this patient rolls into the ER, a class 1 patient might not look sick at all.
They look completely stable.
Yeah.
And honestly, that's fine because they are stable. They don't need a massive intervention right that second.
But then we cross the line into class 2. This is what you call the danger zone. We're talking 15 to 30% blood loss, up to 1.5 liters. That is a big soda bottle worth of blood.
This is the trap. This is exactly where junior doctors make fatal mistakes.
Yeah.
This is where lives are lost unnecessarily every single day.
Let's role play this for a second. Why is this such a trap? If I've lost 1.5 liters of blood, surely I look half dead on the stretcher, right?
That's just it. You don't. You walk in, or at least you're awake on the bed, you're talking, you might be a little pale, maybe a bit sweaty. The nurse puts the automated blood pressure cuff on your arm. The machine whirs, does its thing, and it spits out 120/80.
Textbook perfection.
Exactly. And your brain, as a doctor, which is constantly looking for reassurance in a high-stress environment, says, great, BP's normal, he's stable, let's go grab a coffee and wait for the CT scan results.
And that's the mistake that ultimately kills him.
That is the fatal error. Because you have to ask yourself, why is his blood pressure normal? It's not because he has enough blood, it's because his body is screaming in terror.
What's doing?
It has dumped massive amounts of adrenaline and circulating catecholamines into the system. It has tightly constricted every single blood vessel in his skin, his gut, and his muscles just to squeeze every last drop of available blood toward the brain and the heart.
It's faking stability.
It is a physiological lie. The body is running the engine at 7,000 RPM just to artificially maintain that pressure number. And if you look closely, if you actually practice surgical thinking, you can see the engine straining.
Okay, so what are you looking for? If the blood pressure cuff is lying to me, what tells the truth?
2 very specific things. First, the behavior. He isn't actually fine. He's anxious. He's asking, what happened? Am I okay? Am I going to die? Over and over again. We so often mistake this for emotional trauma from the crash itself.
Right, like, oh, he's just shaken up from the wreck.
Right. But physiologically, that is his brain sensing the initial hypoxia. That is air hunger or perfusion hunger.
Yeah.
And second, and this is the golden rule of trauma medicine, trust the pulse.
The heart rate.
The blood pressure is normal, but the heart rate is 115 or 120.
And for a resting 25-year-old male?
That is way, way too high. If you see a trauma patient with a totally normal blood pressure but a heart rate of 110, you must assume they are actively bleeding to death until you definitively prove otherwise.
You just have to ignore the 120/80 flashing on the screen?
You have to look at the tachycardia. That high heart rate is the body compensating. It is the only thing currently keeping that blood pressure up.
That is the big red flag. The racing heart is the body screaming for help while it's desperately holding the door shut against the monster.
Perfectly put. And if you miss it, if you wait around for the blood pressure to drop, the patient slides helplessly into class 3.
The dam just breaks.
Now we are at 30 to 40% loss. Up to 2 liters of blood gone. The compensation mechanism completely fails. The body simply runs out of tricks. Now finally, the blood pressure plummets.
So by the time the blood pressure drops, you are already deep into class 3 shock.
Yes, you are very late to the party. The patient is confused, agitated, mostly because their brain simply isn't getting enough oxygen to think straight. The pulse is racing, way over 120 or 130. This patient is in incredibly deep trouble.
And the treatment strategy here changes entirely too, right? You can't just give them a bag of saline water anymore.
No, if you have lost 2 liters of whole blood, you need blood. Clear fluids aren't enough. In fact, relying heavily on fluids here can be extremely dangerous, which we'll get to in a minute. But the headline is, Class 3 needs a transfusion fast.
And finally, class 4, the absolute brink of death.
More than 40% blood loss. More than 2 full liters. The patient is barely conscious, incredibly pale, cold to the touch, and extremely clammy. Pulse is over 140, weak and thready.
And the blood pressure.
Blood pressure is basically on the floor, unrecordable sometimes. This is what we call pre-terminal.
Meaning they are about to die in front of you.
Right now. This requires a massive transfusion protocol to be activated immediately. You are literally pouring uncross-matched blood in as fast as you can hook up the bags. You are wheeling them to surgery immediately. There is absolutely no time for scans, no time for debate.
It really emphasizes why identifying class 2, spotting that anxiety, catching that tachycardia early is so incredibly vital. You want to catch them while the body is still winning the fight, not after it has already lost.
Exactly. You want to intervene during the lie before the truth comes out.
So we know what to look for on the vitals charts, but the source material dives into this section called the art of monitoring. It makes the point that it's not just about staring at the high-tech machines. It specifically mentions the canary in the coal mine.
Ah, yes. The kidney.
This was totally surprising to me. I always think of the heart and the brain as the most important organs to worry about in an emergency. Why is the kidney the absolute star of the show for monitoring shock?
Because the kidney is an absolute diva. It is incredibly high maintenance. Under normal conditions, it receives 20 to 25% of your total cardiac output. It demands extremely high, constant flow.
Okay.
So as soon as global perfusion drops, even just a tiny little bit, the kidney immediately goes on strike. It aggressively holds onto fluid to try and keep the central blood volume up.
So your urine output just drops.
It drops incredibly fast, often way before the blood pressure ever changes. It is the single most sensitive real-time indicator of deep organ perfusion we have.
Wow.
The brain desperately tries to stay awake, the heart works overtime to keep beating, but the kidney just shuts down shop and closes the blinds immediately.
What's the magic number we're looking for there?
0.5 milliliters per kilogram per hour.
Okay, let's do the math on that so we can really visualize it. For, say, an average 70-kilogram person.
So 70 times 0.5 is 35. You want to see about 35 milliliters of urine produced every hour.
That's essentially the size of a standard shot glass.
Right, a single shot glass an hour. If you catheterize a trauma patient and you look down and see the bag is totally empty, or maybe it's just getting a few dark, concentrated drops, that patient is in shock.
No matter what the monitor says.
Exactly. Their organs are actively starving. The kidney is telling you the unvarnished truth.
The source expert actually said, watch the bag like a hawk.
It's the absolute best low-tech tool we have. It tells you immediately if your resuscitation efforts are actually working. If you push fluids and give blood and suddenly the clear urine starts flowing again, you know you're winning. You know the cellular engines are getting oxygen again.
So we have our deep understanding of the diagnosis. We have our monitoring tools. Now we have to fix the problem. We are moving into section 4, management. And this is where raw physics and medical protocols just collide head-on.
And it all starts with the most fundamental, unbreakable rule of emergency medicine. ABCDE.
Airway, breathing, circulation.
And notice the order carefully. Airway is always first.
Why is that a common error, though? I mean, if the guy is obviously bleeding profusely from his leg, shouldn't our first instinct be to stop the bleeding?
It's human nature to focus on the blood. It's red, it's dramatic, it's scary. But you have to force yourself to think physiologically. If the patient loses their airway, if they stop breathing, or worse, aspirate their own vomit, they will die of hypoxia long before they ever bleed out.
The source notes mention aspiration specifically as a huge risk.
Yes, a confused, shocked, hypoxic patient very often vomits. If they are lying flat on their back, strapped to a spine board, and they vomit, all that acidic stomach content goes straight down into the lungs.
Oh, that sounds off.
Now you have severe chemical pneumonia and a totally blocked airway sitting right on top of the massive hemorrhagic shock. It's a second lethal problem that you entirely created.
So secure the airway, put a tube in them if you have to, and then only then move to circulation. And here is where we get into some really cool physics. We need to geek out for a second on the fluid dynamics here. The source talks extensively about vascular access and something called Poiseuille's law.
This is hands down one of my favorite applications of pure physics in clinical medicine. Jean-Léonard Marie Poiseuille. He was a French physicist and physiologist from the 1840s. He gave us a mathematical law about fluid dynamics that literally dictates how we save lives in the ER today.
The math behind it is super counterintuitive, though.
It really is. It's all about flow rate. The fundamental question is, how fast can you physically get blood out of a plastic bag and into a human body? Most people assume the math is linear. You know, you use a pipe that's twice as big, you get twice as much water.
Yeah, that makes logical sense. 2 lanes on a highway, double the amount of cars.
But fluids flowing inside a closed tube don't behave like cars on a highway. Friction against the inner walls of the tube slows the fluid down dramatically. The water right in the dead center of the tube moves the fastest because it's furthest away from the walls.
Okay, I'm with you.
So if you widen the tube, you aren't just adding a little more space. You are exponentially reducing the overall percentage of water that is touching the high-friction wall. The math says the flow rate is proportional to the radius to the power of 4.
The power of 4. Let's actually do the math on that for a second.
Okay, take a standard drinking straw. Let's say the radius is 1 millimeter. 1 to the power of 4 is just 1.
Easy enough.
Now, let's just double the width of that straw. The radius is now 2. What is 2 to the power of 4?
So 2 times 2 is 4 times 2 is 8 times 2 is 16.
16. You only doubled the size of the needle, but you mathematically increased the flow rate 16 times.
That is a staggering difference in volume.
It's huge. And this is exactly why trauma surgeons and ER docs are absolutely obsessed with large bore access. In a trauma bay, you will see nurses and doctors completely ignoring those tiny little visible veins in the hand.
They go straight for the big ones.
They go straight for the ditch in the antecubital fossa with these massive, terrifying-looking needles. The orange ones, which are 14 gauge, or the gray ones, which are 16 gauge.
Because a needle that is just a little bit smaller
Might restrict your flow so much that you literally cannot pump blood into the patient faster than they are bleeding it out onto the floor. You lose the race strictly because of the math. A tiny 22 gauge blue cannula is completely useless in major trauma.
So the mantra is, go big for flow.
Exactly. But there's a second critical part to Poiseuille's law, and that is length. Flow is inversely proportional to the length of the tube.
So a longer tube is naturally slower.
Much slower. More surface area means more friction. So those fancy central lines that go deep into the jugular vein in the neck, they're long, thin tubes. They are actually terrible for rapid fluid resuscitation.
Really? Even though they're in a bigger vein?
Yes, because the tube itself is long and thin. You want short and fat. A short, fat IV in the arm mathematically beats a long, thin central line in the neck every single day of the week.
Now, what exactly are we putting through those big, short tubes? Because this seems to be an area where surgical thinking has shifted pretty dramatically over the last couple of decades.
It really has. It used to be that we would just drown the trauma patient in normal saline. Liters and liters of crystalloid fluid. The thought process was simple. Volume's low, so just replace the volume.
But that's changed now.
Drastically.
Yeah.
We now know that pumping in too much saline is actually incredibly harmful. It causes severe acidosis. And crucially, saline doesn't carry any oxygen, and it doesn't clot.
Right.
If you replace lost whole blood with salty water, you are severely diluting whatever clotting factors the patient has left. You are basically making their blood watery.
Which obviously leads to more bleeding.
Exactly.
Yeah.
We call this phenomenon dilutional coagulopathy. So the new modern strategy is called damage control resuscitation. We use actual blood products very early. We aim for a strict 1-to-1-to-1 ratio.
What exactly is that ratio?
1 unit of packed red blood cells, which gives you the oxygen carriers. 1 unit of fresh frozen plasma, which gives you the clotting factors. And 1 unit of platelets, which provides the physical plug. You're essentially rebuilding whole blood on the fly.
You're not just filling the tank up, you're making sure you're filling it with the exact right type of fuel.
Correct. And this careful strategy helps us fight the absolute boogeyman of trauma surgery, the lethal triad.
Man, that sounds like a horror movie title. The lethal triad?
It essentially is. It's a vicious, self-sustaining cycle of death. The 3 corners of the triad are hypothermia, acidosis, and coagulopathy.
Let's connect the dots on that. How do those 3 things actively feed each other?
Okay, start with hypothermia. A trauma patient is almost always cold. Shock itself makes you cold because blood is shunted away from the skin, and when they arrive, we usually cut off all their clothes to examine them in a cold ER. Plus, if you give them room temperature of IV fluids, they get even more hypothermic.
Okay, so their core temperature drops.
Now, the enzymes in your body, specifically the cascade of enzymes that make your blood clot, are highly temperature dependent. They simply don't work when they are cold. So hypothermia directly leads to coagulopathy, the failure to clot.
So because they're cold, they bleed more.
Exactly. Now, that increased bleeding causes worse tissue perfusion, which, as we established earlier, causes the cells to produce lactic acid. That's acidosis.
Right, the cellular suffocation.
And guess what? Those exact same clotting enzymes also don't work in an acidic environment. So the acidosis further worsens the coagulopathy.
And round it goes.
Cold leads to bleeding. Bleeding leads to acid. Acid leads to more bleeding. It is an accelerating death spiral. Once a patient fully enters the lethal triad, it is incredibly hard to pull them back out.
So the entire goal of surgical thinking here is to just never let them enter it in the first place. Keep them warm with blankets and warm fluids, give actual blood, not just cold saline, stop the bleeding surgically.
Precisely. Prevention is really the only reliable cure for the triad.
Now, there is one more concept in the management section that feels totally wrong emotionally, but is apparently completely right medically. Permissive hypotension.
Oh, this one requires absolute nerves of steel from the physician.
Just the name implies we are intentionally allowing low blood pressure.
Yes. In a patient with penetrating trauma, say a stab wound to the belly or a gunshot wound to the chest, where the internal bleeding hasn't been physically stopped by a surgeon yet, we purposely do not try to normalize their blood pressure.
Why? I mean, if the pressure is dangerously low, don't we want to fix it immediately to perfuse the organs?
Think about it mechanically. Imagine a major pipe with a hole in it. The body has managed to form a soft, fragile little blood clot right over that hole. It's plugging the leak, but just barely.
Okay.
If you aggressively crank up the pressure inside that pipe by pumping in IV fluids, what happens to that fragile little plug?
You just blow it right off.
Yeah, we call it popping the clot. You blow the clot off the vessel, and the catastrophic bleeding restarts, often much worse than it was before. You are literally fighting against your own body's repair work.
So you actively keep the pressure low.
You keep it just barely high enough to keep the brain and the heart alive, usually aiming for a systolic pressure of around 80 or 90, but low enough that you don't pop the clot. You carefully maintain this terrifyingly delicate balance until the surgeon can get into the OR and get a physical clamp on that bleeding vessel.
Yeah.
Then and only then do you normalize the pressure.
That is just the ultimate definition of surgical thinking, understanding the physiological mechanisms so deeply that you actively do something counterintuitive to save the patient's life.
It's logic over pure reflex.
Okay, before we completely wrap up, we have
Yeah.
to do a special sidebar on one specific type of shock that is just a massive part of hospital medicine across the board. Septic shock.
Yes, absolutely. Sepsis is a major killer globally, and septic shock is the extreme terminal end of that spectrum.
The definition here in the notes is very specific. It's not just having a bad infection.
No, it's not. It is defined as sepsis with persisting hypotension that strictly requires vasopressors, which are drugs, to physically squeeze the blood vessels, just to maintain pressure, despite already giving adequate IV fluids. And usually a blood lactate level greater than 2.
Lactate again, that's the marker of the cellular suffocation we talked about earlier, right?
Yes, anaerobic metabolism produces that lactate. High lactate means the cells are screaming out for oxygen.
Now, there is a very strict protocol here called the 1-hour bundle, driven by the Surviving Sepsis campaign. What exactly do we need to do in that crucial first hour?
There are 5 key things, and speed is absolutely everything here. Number 1, blood cultures. You need to draw blood to identify the specific bug causing the infection. Number 2, antibiotics. Broad-spectrum antibiotics given immediately.
Hit it with everything.
Right. Number 3, fluids. Usually 30 milliliters per kilogram of crystalloid fluid to try and fill up that dilated tank. Number 4, measure the lactate to see exactly how bad the cellular perfusion is. And number 5, start vasopressors if the fluids don't fix the blood pressure.
Now, there is a very specific nuance here regarding the timing of the blood cultures versus the antibiotic.
Yes. Ideally, you absolutely must draw the blood for the cultures before you give the antibiotics. Because once those powerful antibiotics hit the bloodstream, they might instantly kill the bacteria in your blood sample. And the lab will never be able to tell you exactly what bug it was.
There's a but, right?
But you never, ever delay the life-saving antibiotics if the patient is crashing. If you can't get the blood culture instantly for some reason, you push the drugs anyway. Saving the patient's life right now is infinitely more important than identifying the exact bug tomorrow.
And the drug of choice here, the vasopressor you mentioned.
Noradrenaline, also widely known as norepinephrine. It strongly clamps down on those massively dilated pipes. Remember, sepsis is fundamentally a pipe failure and forces the blood pressure back up.
What about dopamine? The notes mentioned avoiding it.
Not anymore, no. Dopamine has a much higher risk of causing severe arrhythmias, highly irregular heartbeats. Noradrenaline is the definitive gold standard now.
Okay, we have covered just a massive amount of ground today, all the way from the car crash to the complex physics of fluid flow straight into the ICU. I want to try something a little different, make sure this all sticks. Let's do a rapid-fire recap. I'll throw a clinical clue at you, and you give me the surgical thinking pearl. Are you ready?
I was born ready. Let's do it.
First sign of significant hemorrhage in a trauma patient.
Tachycardia. Always trust the pulse, ignore the normal blood pressure.
Best real-time indicator of deep tissue perfusion.
Urine output, the canary in the coal mine.
A patient has lost 1.5 to 2 liters of blood. Blood pressure's finally dropping. Pulse is 120. What ATLS class are they?
That is class 3, hemorrhagic shock. They desperately need whole blood, not just clear fluids.
A trauma patient rolls in with remarkably low blood pressure and a completely slow heart rate.
Neurogenic shock. The sympathetic wire has been cut.
The terrifying lethal triad. Name the 3 killers.
Hypothermia, severe acidosis, and coagulopathy.
And finally, the mnemonic for the immediate killers in obstructive shock.
TCP, tension pneumothorax, cardiac tamponade, and pulmonary embolism. The physical blocks in the plumbing.
You passed with flying colors, and hopefully our listeners did too.
This really brings us all the way back to the core mission of this entire deep dive. Shock isn't about memorizing rote lists for a medical exam. It's about building logical frameworks in your mind. Pump, pipes, fluid. If you truly understand the core physiology, you can walk into any chaotic emergency room, look past the blood and the screaming, and see the underlying mechanical pattern.
It takes the blind panic right out of the emergency.
Exactly. When you understand exactly why you were doing what you were doing, why you were reaching for the short, fat cannula, why you were obsessively checking the urine bag, why you were actively accepting a lower blood pressure in a stabbing victim, you aren't just blindly following a protocol sheet. You are truly thinking like a surgeon. And that is what actually saves lives.
I want to leave you with one final image to mull over. We talked a lot today about high-tech monitors and complex, massive transfusion protocols, but I want you to just picture that simple plastic urine bag hanging off the bed and the analog feeling of a racing pulse right under your fingertips.
The absolute simplest tools.
The simplest tools often tell the deepest, most urgent truths. In a world of incredibly high-tech medicine, sometimes the literal difference between life and death is simply noticing that a pulse is just a little too fast, or the urine is a little too scant, and having the courage to ask why.
Critical independent thinking is still the most important tool in any doctor's bag.
If you found this deep dive valuable, share it with someone. Pay it forward. Because understanding these concepts isn't just academic trivia, it is vital, life-saving knowledge. Thanks for listening to The Deep Dive. We'll see you next time.
Stay curious and stay safe.